Good afternoon, everyone, and good morning and good evening, wherever you are in the world. Welcome to Queen's University Thyroid Nodules CME webinar, talking about the thyroid nodules management pathway. And our title of this presentation today is "What the heck do I do with these lumps?" We have three very special presenters today who I will introduce shortly. I am going to be your moderator. I am the head of the Department of Radiology at Kingston Health Sciences Center at Queen's University. Joining me will be Dr. Annie Garg, who is family physician in the community at the Kingston Community Health Centers. This event, I'll pass it on to Pam Moore, who's our DI coordinator, will give us a few housekeeping messages before we dive into the introduction of our speakers. Pam?
I just want to start by saying thank you for joining us today. So as a reminder, you guys can see the panelists, but we can't see you. So if you would like to interact or ask questions, please use the Q&A box, and those will be addressed more towards the end of the webinar. As Dr. Isla mentioned, it is an accredited event. So for those of you that do require certificates, those will be provided by the Office of Professional Development by Queen's, and those will come a few days after the end of the webinar here. It is being recorded. So again, probably early next week, we will post it up to our website, our Diagnostic Radiology Queen's website, and I'll send out a reminder to anybody that attended the webinar using the email that you registered with. Also, at the end of the session, I will provide a link for you to respond to a short evaluation about the event today. So if you could just do that, just take 2 or 3 minutes just to respond so we can look at improving going forward or what we did well, that kind of thing. So that's really it. And just thank you again for joining us today, and I hope you enjoy.
Thank you, Pam. I would also like to thank our sponsor of this event, C-Mode. C-Mode is an artificial intelligence company from Australia who provide rapid AI augmented ultrasound reporting. And thank you to C-Mode for helping bring this webinar to you free of charge. So let's introduce the power trio in no specific order. These are going to be your main speakers today. First of all, we have Dr. Robyn Houlden, who's an endocrinologist, professor, and chair of the Division of Endocrinology here at Queen's. She's a provincial provider for e-consults in endocrinology. Management of thyroid nodules is her area of expertise, or one of her many areas of expertise. She's been involved in the Diabetes Canada Clinical Practice Guidelines for over 20 years and chaired the 2018 edition. We have the steady hands of Dr. Russell Hollins, ENT surgeon, who's the former head of the Department of Otolaryngology here at Queen's. He has been an active contributor to the medical education curriculum as elective director and a preceptor for clerks and residents alike at Queen's University. He has a strong interest in leading advanced CME in the management of sinonasal disease and thyroid disorders. And last but not least, Dr. Andrea Gallo, who has a knack for making the complex simple, and she will be talking about thyroid ultrasound and TIRADS. She's a women's imaging specialist here at Queen's University in the Department of Radiology, trained in Columbia and Toronto, where she completed 4 years of fellowship in breast imaging and women's imaging. She's been a speaker at the OAR, which is the Ontario Association of Radiologists, annual breast imaging symposium, as well as multiple conferences overseas. Currently, she serves as the director of ultrasound in the Department of Radiology and has led the implementation of TIRADS in the Southeast Ontario region. So welcome to all three of our speakers. Just a slide on bias. The speakers are solely and fully responsible for developing the program content, and the speakers are not receiving any form of honorarium. These are their disclosures. and our disclosures as the moderators. So there's 3 learning objectives here, and we hope to have a very interactive and informative as well as interesting discussion. And the keyword here is discussion. So as Pam said, please make sure to post any comments or questions in the chat, and we will do our best to get to all of them. So we want to describe the incidence and significance of thyroid nodules, perform the workup of a thyroid nodule using care pathways, which we will describe, and discuss the role of various specialties in the care of a patient with a thyroid nodule with your patients and colleagues. So we've broken up the webinar into 5 parts. There's going to be a pre-test. So this is an interactive part where we will ask you questions, and then your recorded answers will be discussed at the end of the webinar. We'll discuss the epidemiology of thyroid cancer and nodules. We will dive a little bit into TI-RADS reporting, the importance of TI-RADS in your clinical assessment of your patients. We will dive into a discussion of the thyroid nodule care pathway, and we will finish it off with some case studies showing you applications of all of the stuff we've discussed from 1 through 4. So I'll pass it on to Dr. Robyn Houlden for the pretest. Robyn?
Okay, here we go with the pretest. We have a bunch of questions. We're not going to give you the answers now, but we're going to repeat it at the end and you'll see the right answers. So the first question is, thyroid nodules can be detected by ultrasound and up to what percentage of the general population? Is it 16%, 35%, 68%, or 90%? You go ahead and vote for us now. I was just trying to vote and it said I'm not allowed to vote, so that's good. I might have skewed the answer up a little bit. And do we get to see that answer now?
Do you want to see it now, or would you like to wait till the end?
It'd be kind of fun to see it now if you can
Sure.
show. Yeah.
Yep.
Ooh, we've got some people saying 35%, some people saying 60, and some people saying a horrifying 90%. Okay, that's great. Let's go on to the next question here. The rise in screening for thyroid cancer over the last decade has been associated with what change in thyroid cancer mortality? So we've seen a rise. Has there been a significant decrease in thyroid cancer mortality? Has there been a small decrease or no change in thyroid cancer mortality despite this increased screening and detection? And then whenever you think you've got enough answers, if you want to show that, we'll have a look at that. And we're all mixed all over the place. That's great. We'll see at the end whether it's been a decrease or no change. And then ready for the next question. What's the 5-year survival rate for thyroid cancer overall? So the overall 5-year survival rate, 50%, 80%, 90%, or 98.4%. And we people thinking there's probably a pretty favorable prognosis here, but once again, kind of mixed between 80 to that high number of 98.4. Okay, and then I think we've got one more question. What's the risk of malignancy with a TI-RADS 3 thyroid nodule? So TI-RADS 3 is a mildly suspicious nodule. Is it less than 5%, 5 to 10%, 15 to 30%, or 30%? And as I say, we're going to look at all of these at the end and we'll see how the voting's changed. And right now, yeah, we're kind of once again spread, but a lot of people thinking that the risk is pretty small, less than 5%. Okay, well, that's great. Let's go on and start to look at some of this data in a bit more detail. So we think about thyroid cancer. It's actually the 10th most common cancer. It's the 5th most common in women. And it's actually the most common cancer in young people, people between 15 to 29. Well, what happened in around 2012 is we saw this rapid increase in the incidence, a lot more cases being picked up. And if you look at that figure I'm showing you over there, that the yellow curve on that image on the left is the 2012. And then if you look at the black one underneath it, it's 2016. And you can see that the incidence is starting to drop. And the feeling is that the incidence really started to pick up in 2012 because we started overdiagnosing it. With modern imaging, we were picking up a lot of lesions and maybe over-investigating them, over-treating them. And now there's a lot more conservative guidelines related to screening and following these nodules. All right, well, if you see the next slide. So there wasn't anything unusual that happened that would explain this rapid increase. We weren't all exposed to nuclear fallout here in Canada or anything like that. It's really felt that that was just from increased detection from nodules being picked up on imaging. And if you look at this picture here, the bottom two lines, the ones that are kind of running along the baseline there, that's mortality rates. So even though the incidence was increasing, the mortality was not changing at all. And so it was suggesting that we weren't picking up more aggressive, nasty thyroid cancers. The mortality was not changing at all despite this increased incidence. And then on the next slide, so once again, just to sort of summarize, the rising incidence is felt from increased pickup from diagnostic imaging. We were detecting more nodules. We've been doing more biopsies, we're making more diagnoses, but most of these diagnoses have just been very small papillary thyroid cancers. And it's really very questionable their clinical significance. It's felt that a lot of people, normal people, 1/3 of adults will have small areas of papillary thyroid cancer, and the majority will not cause any problems, affect anybody's life expectancy in any way. And there is a potential for harm with overtreatment. So if we over-investigate, over-treat, there is a potential for harm. And if we see the next slide, the biggest example of overtreatment and potential for harm comes from South Korea. And apparently in South Korea, they started to do routine screening for thyroid cancer around 1999. And what happened when they started doing this routine screening is the rates of thyroid cancer just escalated unbelievably. Highest rates worldwide with this routine screening with ultrasound of the neck. And in 1993, it was 15 times what it had been. I'm sorry, in 2011, it was 15 times what it had been in 1993. And as you can see, in 2011, they're diagnosing like 40,000 people in this relatively small country of South Korea. And despite picking up this incidence, once again, if you look at that curve on the far left, no change in mortality. And what they found is that the size of the tumors they were excising was repeatedly getting smaller and smaller. More than half were under a centimeter. And just to show you that there is that potential for harm, 11% of these cases were developing hypoparathyroidism, which is a nuisance to treat. It's hard to treat. And 2% were getting vocal cord paralysis, the two big risks of thyroid cancer surgery. So South Korea, and I think they're trying to curb that epidemic now and really discouraging this aggressive routine screening. There's no body worldwide that recommends routine screening for thyroid cancer. Okay, and then we get ready for the next slide here. Most of the cases of thyroid cancer that we saw in that window of time where there was that increased incidence being picked up, it was with papillary thyroid cancer. And there wasn't any sort of increase in the more aggressive forms of thyroid cancer. It was always in that benign, more or less, I should say, less aggressive type of thyroid cancer, papillary, no increases in medullary anaplastic. Okay, and the next slide. So we just have to be a little bit careful that we're not picking up too many cases, and we have to be careful with our imaging. We have to be careful which nodules we biopsy, and we're going to look through the TI-RADS reporting system, which discourages biopsying of smaller nodules, and particularly nodules so they don't have worrisome features. There's even a move now that that even some small papillary thyroid cancers could be maybe even be monitored with active surveillance rather than having to operate and take all of them out. And I think Dr. Hollins will be talking more about that in his presentation. All right, and the next slide. Now, there are some people we have to maintain this high index of suspicion for. So people that have a history of head or neck irradiation, they get a higher risk of developing thyroid cancer. Typically occurs about 20 to 40 years after exposure. People who've had total body irradiation for bone marrow transplant are also at higher risk for thyroid cancer. Young people that were exposed to nuclear fallout have a higher risk of developing thyroid cancer. So most of the cases in Chernobyl were occurring in young people that were exposed to it. And there are some people that will come into you with genetic syndromes. I'll tell you that they have a condition called multiple endocrine neoplasia running in their family. They're at high risk for medullary thyroid cancer. They have to be actively monitored and managed. And there are some other forms of familial medullary thyroid cancer, but this is certainly the minority of our patients. But if people are describing these things, these are classic risk factors. Okay, in the next slide, it's turning over to Dr. Hollins now.
Okay, so a couple of things that came to mind from Robyn's talk there. I just wanted to mention one of my former colleagues, Dr. Stephen Hall, did some epidemiologic research around thyroid cancer and actually showed that the increased incidence in women was directly correlated to the increased use of ultrasounds, women getting 3.5 times as many ultrasounds as men over a given period of time. Which my perspective was that women go to the doctor a lot more often, and we don't go often enough. So that's been pretty consistent with some other anatomic sites as well, actually. So one of the reasons that this whole thing came together, this talk, was partly I had received a series of ultrasound reports on a single patient with ultrasounds done at a single institution, all of which reported the nodules really differently, which was really frustrating to me. And I'm sure the family doctor was just like, I don't even know what to make out of this at all. So it was part of the impetus for what led to deciding to do this talk. So it is a sort of a topic that can bring some frustration at all levels. And so from the perspective of somebody that does thyroid surgery, you know, what I've learned over the years and what most of my colleagues will say is that important things to remember are that nodules in general are just incredibly common, and the vast majority of nodules are benign. Maybe 5% are malignant. I think our stats on this are still, you never really know for sure, but let's say somewhere between 3 and 5% of the nodules are malignant. And as Robyn was pointing out there, of those malignancies, a lot of them are small papillary carcinomas that are not necessarily serious in terms of consequence. We do the next slide. So how does this show up, and what is the difference? So the difference in the literature that precedes the last, say, 20 years, the relative number of malignant cases in nodules was higher. And this is because before the advent of routine use of sensitive imaging, people didn't come in with a thyroid nodule unless they had a physical finding or a symptom that was directly related. You know, and you get the patient say, oh, I felt a lump, or a primary care provider picked up a lump on an examination. So these lumps in relative terms to the ones we now see were on average bigger lumps. And maybe in the sense that they were now noticeable, were more aggressive. And nowadays, you know, back in the early 90s, people started writing into papers this term incidentaloma, which was viewed initially as a sort of humorous, and now it turns out that's probably somewhere between 95 and 98% of the cases that we see in thyroid clinic and in the head and neck clinics. One of the things I've noticed in my practice is that a patient is referred with a finding of a thyroid nodule, and they went to their physician with a complaint of some feeling in their throat or their neck, a feeling of pressure in the neck, something we sometimes call globus, a feeling of discomfort, and an ultrasound was ordered. The other way that it still shows up, once in a while, we still get patients who come in and they have a physically palpable nodule. So I don't think that, we're necessarily doing things wrongly, but I also think that this interesting feature that the outcome of treatment of thyroid cancer has not changed over the course of time, whether you look back 40 years ago or now. Let's do the next slide. So I have a couple of just simple points to make about when patients show up with these kind of symptoms. We always obviously start with the usual history and physical. And if the symptom is this globus sensation, this pressure, fullness, foreign body sensation, or some kind of mild dysphagia, my recommendation is that if there's also a negative examination on physical exam, then the next step is not to order an ultrasound. I would suggest the next step would be to order a barium swallow, which is a much better test for throat symptoms and swallowing dysfunction. Old-fashioned test for sure, still very sensitive and still essentially the gold standard for mild to moderate dysphagia or throat discomfort symptoms. The other interesting thing about large thyroids, the largest thyroids are often not the malignant ones, the big goiters that we don't see super often. But you can have a very large unilateral goiter pushing the trachea quite far over to the other side, and the patient will be asymptomatic. In fact, it's usually just bilateral large nodules, which are the occasional ones which cause physical compression, one of the less common reasons for surgery, but certainly a valid one. Let's do the next slide. Oh. So this is my main point to make to everyone is if you found a thyroid nodule, don't panic and maybe help your patient understand that it's okay. There's no reason to be too concerned. We'll figure it out, and most of the time it turns out not to be particularly serious. Next slide. So a little bit of reassuring information. Most of the literature agrees, there's always this a little hard with these kind of big studies of things, that if you've got more than one nodule, the risk of malignancy is generally lower. So solitary solid nodules carry a somewhat higher risk of malignancy, although still fairly small risk. Solid nodules have a higher risk of malignancy than cystic nodules. And in fact, most of us believe that basically cysts are never cancer. There's probably some really rare exceptions to that. But you can generally be reassured if the thing is mostly fluid-filled, it's nothing to worry about. So overall, again, most nodules are benign, and most thyroid cancer is non-aggressive with excellent survival statistics. Let's go to the next slide. This is some data from the Cancer Care Ontario website, or maybe, sorry, it's the Canadian Cancer Society statistics, never mind. So of the thyroid cancer cases that were discovered in 2024, the estimated 5-year survival for all thyroid cancers is 98.4%. It represents 0.4% of all cancer deaths in the country. And of the different presentations, the vast majority are localized, which means it's a single lesion in the thyroid. And on occasion, there are regional metastases, so that's the next higher. So regional metastases in this case means lymph nodes in the neck. And much less commonly, there is distant metastatic spread. Next slide. And the other part of the information from that same source is that if there is cancer isolated to the thyroid, the 5-year survival rate is 100%. And then even with spread to the lymph nodes, this is one of the more unusual things, is that when it spreads to the lymph nodes, the survival rate is still very close to 100%. It's only when thyroid cancer metastasizes to especially the lungs and other less common cases where it's distinctly invasive into surrounding structures like the trachea or the recurrent laryngeal nerve. And again, that's the smallest percentage of all the cases. Next slide. So I'll leave it to Andrea to tell us a little bit about ultrasounds.
Okay. Thank you for being here. So I just want to mention some minor details about the TIRADS. I know it could be a little bit, a lot of detail, but I just want to explain what TIRADS mean. TIRADS mean Thyroid Imaging Reporting and Data System. So this TIRADS was released in 2017. There has been like significant studies about thyroid nodules on how to establish good systems for classification and try to give appropriate risk for these nodules. The TIRADS is one of the most recent ones and has been working much better than others. Basically, it gives a 5-point classification, trying to establish the risk of these thyroid nodules based on the features on ultrasound. And the idea of these TIRADS is to identify better what is really a malignant thyroid nodule and reduce the unnecessary biopsies of benign thyroid nodules. Next slide. So in the past, it was very complicated with a lot of negative FNAs and unnecessary procedures. So the specificity was quite low. The detection of small cancers was also low. So there were complicated reports, as Russell mentioned, too many nodules described in each report. So this definitely appear as a necessity to improve the detection and the reporting of the thyroid ultrasound. Next slide. So currently, we're using TIRADS. It's a very useful risk stratification tool. And so far, is the validated guideline that has been working better. It's not perfect, but definitely it's really, really helpful. So what is most important is that it's really helpful for us to detect which nodules need FNA or biopsy. And but we need to be very careful that it's not only the recommendation that we're going to be given on the ultrasound report. Of course, you as a general or family physician, you need to establish comorbidities, life expectancy, and other factors that may be considered before sending your patient for thyroid biopsy. Next slide. So just to summarize a little bit the details of the TIRADS. So on TIRADS, we assess 5 details or 5 features of the nodule. So we assess composition, echogenicity, shape, margins, and echogenic foci. So those are based on the sonographic features. Each one of them give 1 point to the nodule, but the last one, the echogenic foci, we can choose all that apply. So this is the kind of the little category that give more points to the nodule. So we need to consider that this is operator dependent, that there is a little bit of variability in each person reporting the study. But the idea is that we have been trying to be very consistent with imaging, try to reproduce every single test in the same way, try to do the same measurements of the nodules, and try to make it more consistent so we can give a better score for every single nodule. If you notice, the first 3 categories, TIRADS 1, 2, and 3, are low or mildly suspicious or not suspicious at all. But when we talk about the TIRADS 4 and TIRADS 5 is when we are going to start recommending biopsy that they have higher risk of malignancy. If you look in the box on the right, the TIRADS 1, 2, and 3, they have less than 5% risk of malignancy. And the higher the size of the nodule, the higher the score of the nodule, the smaller the size for fine needle aspiration. Next slide. Just to point more of the same, basically the use of TIRADS definitely improve the definition of the risk on every nodule on ultrasound since the TIRADS system was released. Next slide. So there has been some studies trying to evaluate how good the thyroid system has been working. And I just want to mention that the specificity is going up. The sensitivity has been good most of the time, but the good thing is that the TIRADS, which was released in 2017, is the one that helped us to give a proper score for every single nodule. And the idea, if you look at the picture on the right, the ACR-TR, which is the current TIRADS recommended for the American College of Radiology, actually recommend biopsy of less number of nodules, which is very helpful. So we are biopsying less and less benign nodules currently. Next slide. This is just to emphasize that the specificity is getting better on using the TIRADS on ultrasound. Next slide. And also important to identify that AI is one of the tools that we will be using soon. There have been some studies evaluating the use of AI, and actually the numbers are quite good. AI-assisted tools are actually doing pretty well, similar to the radiologists. And we probably will be using soon AI assistance as well. Next slide. So just to mention that we are still trying to improve. TIRADS is not perfect, but ideally we need to use it in a very mindful way. AI will help us a lot, but we need to keep pushing ourselves to do better every day using our TIRAD assessment. Next slide. Okay, now I'm going to give the word to Robyn.
Oh, that's great. This AI thing sounds really interesting. Real wave of the future stuff here. Okay, so
It's gonna take all of our jobs away, Robyn. So
yeah, you guys are all being replaced by some master AI. All right, so we get a lot of referrals in endocrinology for thyroid nodules, and so we got together as a group and we created a care pathway that we thought would be helpful and we could use to help local care providers, and it would also make sure that we're all doing the same thing. So I'm going to show you pieces of our care pathway that we created, and then we're going to show you the link if you want to look it up online. So anyways, the first thing we say is the checklist. First step we're going to do is look for red flags, things that would maybe make us want to make a referral sooner than later. So change in voice, hoarseness, rapid growth, obstructive symptoms, stridor. And then the next step is we want to think about whether there are risk factors, the ones that I was showing you. So we're going to take the time to ask about head and neck radiation, whole body radiation, if they were exposed to nuclear fallout. And I actually have had people in Kingston that have told me that they were in Chernobyl at the time of the big accident. And then we're going to take the time to ask about family history of thyroid cancer. And then the next step is we're going to look for signs and symptoms of hypo or hyperthyroidism. And then the next step would be we're going to measure a TSH, and we're going to go through this all in a bit more detail in a second. And then the next step would be we're going to think about what this nodule's like and whether there's lymph nodes and worrisome features, if it's hard and fixed. And then definitely the core of it all is the thyroid ultrasound with the TIRADS reporting. And it has just revolutionized everything in this field. It's been amazing. Okay, the next slide is here's what the care pathway looks like. And I've got down there at the bottom of the slide where you can look it up. We're going to show you another link later on. But it's meant to help the local providers in the area know how to deal with thyroid nodules. So often these things are picked up on other types of imaging. So if you get a report about someone finding it on CT scan or MRI, you're going to really want to confirm that it's there, and you'll try and confirm it with a thyroid ultrasound, a dedicated thyroid ultrasound, and you're going to ask for the TIRADS reporting. If TIRADS reporting isn't being offered in your area, it's time to speak to your radiologist and say, can you get up to speed? And Andrea could certainly guide people on how to get the training they need, or we could get the artificial intelligence to come into your area and take over. No, I'm just teasing. Okay, so we have confirmed the presence of the nodule on the ultrasound. Next slide. And we're going to look for these alarm features, the ones that would make us want to get this person seen quickly. And the next slide says, if the patient starts telling you that they're developing a hoarse voice, that would suggest maybe a local invasion of the vocal cords. They've got trouble breathing. They've got stridor, or the thing is growing really fast. Those are serious things. You want to get ENT to see them urgently. And certainly if they're having trouble breathing, you'll want to send them to the emergency department. Okay, but if those alarm features aren't present, we'll go to the next box, next slide. We're going to ask about symptoms of hyper and hypothyroidism. We're going to take the time to feel these nodules and look for the presence of lymph nodes in the neck. And then you're going to ask about those things that would maybe want you to get them seen faster by an endocrinologist. So they start telling you, oh, I was growing up in Chernobyl when the accident happened, or we have a family history of multiple endocrine neoplasia, or we have relatives that had medullary thyroid cancer, or I got mantle radiation many years ago for Hodgkin's lymphoma. You would say, huh, let's get you off to endocrinology, and we'd be happy to see those people. But most people are going to say no here, and so your next step is to measure a TSH. And if we go to the next slide, we'll show you why the TSH is so important. So if the TSH is normal or high, we're just going to look at the TIRADS reporting. But if the TSH is low, it's possible this person might have something called a hot or a functioning nodule. And so we're going to make sure that they're not overtly hyperthyroid by looking at the free thyroxine and the free T3. And then we're going to also want to get a thyroid scan. And if the thyroid scan shows a hot nodule, we don't need to worry about malignancy. We could get that person seen by endocrinologists. We might need to manage them for hyperthyroidism, but we're worrying about something different. We're not worrying about the chance of malignancy in a hot or functioning nodule. Okay, but these hypofunctioning nodules with a low TSH or people with normal thyroid function tests, we're going to look at the TIRADS reporting next. Okay, so then we're going to go down the algorithm a bit more. Next slide. So these are the nodules that we really don't worry about that I've shown you here. So if the radiologist says it's TIRADS 1 or TIRADS 2, those guys don't need any follow-up. The odds of them ending up being malignant at any point is just so small, there's no follow-up needed. And then for the other categories where there's a little higher risk of malignancy, if they're really, really small, the odds of those ever enlarging and causing problems is considered to be so low. Then in the TIRADS reporting system, they say no follow-up needed. So when you get these reports back, you could look up the pathway and you could just refresh your mind at the time and say, oh, this thing is so small, no follow-up needed. Most TIRADS reporting will actually include this. They'll put these recommendations at the end of the reporting. Okay, so those are ones no follow-up needed, low risk of cancer. Next slide is the ones that are maybe a little bit bigger, and maybe we want to follow them for a bit, but they're not big enough to merit biopsy. So remember, we're trying to downplay not biopsying them all. We don't need to pick up so many cases anymore. So these are ones we're going to want to watch for a bit, and we're worried about growth. And they have some recommendations there based on their TIRADS reporting, how often we have to image them. So if they're really high risk, we're going to do it annually. And if it's a little lower TIRADS risk, we're going to do it 1 in 3, 5 years. If there's no growth over 5 years, most of these nodules we don't need to follow anymore. It's all over. On the other hand, if on the reporting they're showing us an increase in size, and here again, your radiologist doing the reporting will tell you whether they think there's a significant change compared to the last ultrasound, then we'll worry about that. A good reporting radiologist will be trying to look for the oldest imaging, and they'll be trying to compare the current one to the oldest one to really see if there's been any sort of significant increase in size. Okay, so as I say, some of these, if they're not growing 5 years, really stable, we get to stop. But if there is a significant increase in size and the definitions there, then we're going to want to keep watching these guys. And some of them will finally meet the criteria for biopsy, and others will just have to keep watching a little bit longer. Okay, and then the next slide. The next one, oh yeah, that's just me just saying no growth, 5 years, you can stop. And then the next slide, if they show signs of growth, we're going to have to keep the follow-up going a little bit longer. And if they finally meet the criteria for biopsy, we're going to have to biopsy. Okay, and then the next slide is There's a high-risk category just before this. Maybe just go one more slide. Yeah, these are the ones that we really worry about. So if they're TIRADS 4, TIRADS 5, then we're going to want to send them right off to radiology for biopsy. And it will vary with your center who's happy to do thyroid biopsies. Certainly most places interventional radiology will want to do that. In some centers, you might have an endocrinologist that's happy to do your biopsy for you as well. Okay, and then the next slide is what to do with the biopsy reports. So if you're lucky, it's benign. And then the next one is non-diagnostic. Unfortunately, with non-diagnostic, you have to repeat it. It just means that the cytopathologist didn't get to see enough tissue to diagnose this. Third category is also really frustrating. It's called atypia of undetermined significance. And these ones, unfortunately, we still have to watch. And often we have to repeat the biopsy. These are the sorts of ones that an endocrinologist is happy to follow with you. So if you're in primary care and you get an atypia report back, then this would be certainly something you could refer to an endocrinologist. We'll be factoring in the bigger picture and be happy to follow them for a while. And then the next couple of categories are, yes, if it's a follicular neoplasm, they should go to ENT. If it's suspicious for malignancy, certainly to ENT. And then the last category is it's malignant to ENT. In some centers, there might be a general surgeon with expertise in endocrine surgery, but certainly in most centers, it's the ENT surgeon that would be happy to see these cases. Okay, and then the next slide, I'm not going to really spend much time on. This is just sometimes with some of the benign nodules, we do watch them and we sometimes repeat the biopsy. And if you get all the way down on this part of the care pathway, this is typically what an endocrinologist would be doing and worrying about. But there are sometimes benign ones that we'll still watch for a little while longer, and maybe repeat the biopsy. Okay, and the next slide is, I think we're on to Russell now.
Yeah, thanks. Again, I have a couple comments. I just want to make sure those couple points are clarified. One of the things that's maybe important to be a bit specific about is what kind of hoarseness are you dealing with? The hoarseness that comes from, straining your voice, or the more sort of serious laryngeal lesions is not the same as the hoarseness that comes from a recurrent laryngeal nerve injury. So when it's a thyroid pathology or some other form of recurrent nerve, it's a breathy hoarseness. They just can't, the vocal cords aren't closing. So there's all this air escaping when they talk, and there's this tendency that they have to take a lot of breaths just to complete speaking a sentence. So having that distinction may be helpful in terms of, you got a person with a small thyroid lump on ultrasound and they're hoarse, but they also smoke, or they're a teacher who, teaches 30 kids a day for 6 hours a day. So keep in mind kind of the context of what the hoarseness is around. The thyroid biopsies in Kingston, for example, I also have a thyroid clinic and do biopsies under ultrasound guidance. And we just happen to have an interventional radiology department, which is overwhelmed with, just so much to do that, and Omar could speak to this, but basically a bunch of years ago, we said, well, do you mind if we do this? And they were like, totally, go ahead. And so myself and a couple of the endocrinologists do our own biopsies and are happy to do so. So there's a few paths that you can refer patients for suspicious nodules. One of the troubles with the non-diagnostic category is sometimes the nodule is actually a long way in the thyroid. It's difficult to get an accurate sample, and you get these repeated non-diagnostic. And sometimes those, it's worth getting them checked by a specialist, but sometimes those are actually quite appropriate to just monitor with serial ultrasounds. Ultimately, it really depends on the situation. So fine needle biopsy is in a sense, TIRADS is a good guide. Fine needle biopsy is a really reliable way of getting information about the nodules, and it's non-invasive. It's just a needle. There's literally no risk from this. The worst I've ever seen from a needle biopsy was a bruise that took a few days to go away. And they're reasonably sensitive. They're quite specific, and the positive predictive value is good enough to be reliable. And of course, it's not perfect. It's just a needle sample, so there's always going to be some cases where you're still uncertain You know, my perspective, sort of the broad picture for me, is that there's sort of 4 categories, and the 2 ends of the categories are great because you know what to do, and the middle categories are like, well, we're still a bit suspicious, but we don't know for sure what to do. We're going to have to look at the other characteristics of this patient and this nodule to make a decision as to, are we monitoring or are we doing surgery? Next slide, please. So there's a bunch of things that we can do to try to improve our accuracy, and of course, you know, the more you do, the better you get at it, of course, just like any technical thing. We unfortunately do not have access to a cytopathologist, so in some centers there's an actual technician who takes the sample and checks it right there when the patient's with you to see that it's an adequate sample. We just don't have the resources here to do that, which is why we probably have a higher rate of patients who come back for a second biopsy. Really small nodules, and strangely enough, really big nodules, can be difficult to get an accurate biopsy. I had a really strange circumstance with a patient who had a positive cancer diagnosis, and it turned out it was 2 millimeters of this 6 centimeter benign thyroid nodule. So it just happened to sort of by luck or by misadventure in some ways actually hit the needle into the part that had the few cancer cells. So that was kind of an interesting case, teaching case for me in a way. We do a bunch of aspirates on each individual nodule, and so the non-diagnostic cytology is not negative, and the risk is probably still very low, but you haven't ruled it out. And there's points, as I said, where you might say, okay, we'll rebiopsy, but if it keeps being negative, then you might just kind of monitor that. Let's try the next slide. So I have some reassuring news. So again, the fine needle biopsy holds significant importance in evaluating the nodules. The negative predictive value is 95% for benign cytology, and the positive predictive value is over 99%. So if I get a biopsy that says it's likely malignant or is malignant, I trust that that person is probably going to have part of their thyroid removed. The other reassuring news is if you get a false negative biopsy, because that can happen with basically any test, and you don't do surgery, the actual consequence is not serious. There's been no deaths reported in any studies that showed false negative biopsies that turned out to have malignancy later on. Next slide. And that's kind of in keeping with what we know about how thyroid cancer mortality hasn't increased. The majority of even the cancerous nodules are not aggressive. So fine needle biopsy reports are very useful at the ends of the spectrum. The indeterminate results should be retested. The actual rates of malignancy do vary. So when you get a TIPIA report or a follicular, you know, my own experience has been that the number of those cases that turn out to be malignant is actually less than the estimate on the reports. So we have to look at all the different factors. As I mentioned earlier, if there's multiple nodules, if the nodules are growing more quickly, you know, some very rare case of family history. I do find that if you've had a report saying it's one of those intermediate categories, repeating the biopsy sometimes just makes things more confusing. So I don't always do that. I'm more keen to monitor nodules where we're sort of a little bit suspicious, but not necessarily needing to do anything surgical. Next slide, please. So the malignant nodules tend to grow faster is something we've definitely seen. More than 2 millimeters per year in 2 dimensions, or a 20% increase in volume is definitely suspicious and should be rebiopsied. So, you know, because even the benign things do grow, they tend to grow. My other observation is that biology is not particularly linear, so although things may grow over time, it's not like it's every year it's the same amount. It might be a little jump once in a while and then nothing for a while. So slow growth is generally okay. Next slide. So the practical advice is multiple nodules, you can actually reassure patients. Slow and no growth is better. And at times, you know, I've often find it interesting that it's a bit more of a dilemma knowing what to do with the patient where we're not that suspicious, but we don't know for sure, than we are with the person who had a frank malignancy diagnosis and we followed them for 5 years and then we stop. So I still think it's actually pretty reasonable, you know, if we've got, you know, let's say 3-4 nodules that are slightly suspicious, no concerning findings on biopsy, and they haven't been growing, we might return that patient to your care for routine ultrasounds every once in a while. And at a certain point, you can quite safely say, look, it hasn't changed in the 5 years. We could just stop looking at it. And Robyn did make reference to that earlier in the slides. We try to make sure we get the ultrasounds done at the same place. I have patients who come from all over, obviously, like all of us here, from anywhere from sort of Prince Edward County to Perth and Smith Falls and Prescott. And there are good ultrasound centers in all those locations. And if that's where they had their first ultrasound, I'm going to order the ultrasound at the same place so they can compare the films. Next slide, please. So the other thing, I was told this in medical school, actually I was told that up to 30% of cadavers have thyroid cancer in them, and then an actual more recent review showed over 10% of cadavers have thyroid cancer, and obviously they wasn't doing anything, so those don't matter. There is and Robyn alluded to this, there's a multi-center study being directed by somebody from Toronto, I believe, of actually not doing surgery on small biopsy-proven thyroid cancer, specifically papillary cancer. And because they're probably not going to cause any trouble. The other, and perhaps anecdotal piece of information I'll share, because I've been doing thyroid surgery for a while, every case of sort of quote unquote bad thyroid cancer that I've seen, all the ones that I've seen that are metastatic to the lymph nodes or invasive, actually showed up that way at the point of diagnosis. So it wasn't these cases where we incidentally found a nodule that had no symptoms and was just sitting there maybe growing a little bit. All the ones that were more serious started that way. So I do believe that that most of the cases that are the most important to take care of, there's something different about their mutation right from the get-go. And these are the ones, it's disappointing in a sense because, it'd be nice if we had this system that could detect those before they became bad, but so far, not the case. Next slide, please. So I guess we're on to the cases, which I think that's Robyn, right?
Yeah, that's me. Okay, so we're going to show some cases, and they're messy, just like real life. So I think this is great. But we'll show you how my care pathway sort of guided you, and then we'll see how the TI-RADS reporting was so critical to the management. So this patient at age 59, they have a CT scan of the chest done, and it's for pleuric chest pain, and it shows a 17 millimeter nodule in the right lobe of the thyroid. So not unusual at all that you're doing imaging for another reason, and the radiologist says, and there's a nodule in the thyroid. And I said to you, one of the first things you want to do is do an ultrasound, really make sure it's there before you spend much more time on this. And so the dedicated ultrasound's done with the TI-RADS reporting, and it's TI-RADS 4. So it's got some worrisome features. It measures 1.8 by 1.9 by 3.9 centimeters. And that actually 3.9 means it meets the criteria for biopsy in that care pathway I was showing you. So we do the fine needle aspiration biopsy. It could be interventional radiology, could be an endocrinologist with an interest in doing this, and you get non-diagnostic back. And non-diagnostic, unfortunately, means you can't rule out cancer. You should repeat the biopsy. So it gets repeated, and there's no timeline when you should do it, but you can do it right away, or you could wait a couple of months, depending on whether the patient's willing to do it again right away. And non-diagnostic again. Now, there is a limit as an endocrinologist how often you can ask people to do fine needle aspiration biopsies. It's not an incredibly painful procedure, but people aren't incredibly fond of it either. If you have to describe to a patient what it feels like, it typically feels like a wasp sting. So that's what it feels like. So I've got two non-diagnostics that isn't super worrisome, but I'm going to watch it now as an endocrinologist. And I would be more than happy if I got this referral from a primary care physician. So I watch it for a while. It doesn't grow. And I say after 5 years, that's enough. I can stop. So next slide is just how the care pathway would have helped me. I would have gotten that TI-RADS reporting back. It would have fit the criteria for a biopsy. I would have sent them off to interventional radiology. And the next slide would be, I got back the non-diagnostic. It tells me I have to repeat the biopsy, which I did. And then I'm still getting non-diagnostic. It's frustrating, but I'm going to watch it. And the next slide just shows that if I watch it long enough and it doesn't grow, then I think I can be confident and I can stop. So I'll let Andrea comment a little bit more about TIRADS here.
Okay, so I just select a couple of pictures for you to point. Here is the little nodule in the right thyroid lobe on the CT that Robyn was describing. On the top is the corresponding ultrasound at that time, is from February 2021. And if you follow my arrow, oh no, you can't follow my arrow. Maybe Omar will point the nodule on the top. And at the bottom is the ultrasound from October 2024. So you can still see the same nodule. There's no significant change, and definitely has been pretty stable. Next slide. So just some learning points on this case. CT scan findings don't always need to be follow-up. Again, we need to consider patient's age, comorbidities, and check with previous tests. Maybe we can see this little nodule on an old CT scan, and maybe we don't need to suggest an ultrasound, for example. We don't need to do follow-up if there is a stable for 5 years. So that's the number that you need to remember. And definitely the non-diagnostic biopsy is an unclear report, and it is suggested to don't be ignored. But of course, the approach should be individualized. Next slide. Okay,
well, here's the next case, and multinodular goiter. And Russell was mentioning that some studies are suggesting perhaps a little lower risk of malignancy in the multinodular goiter compared to the solitary nodule. And the person's 74 years old, and Andrea was saying, always look at the whole picture. If it's a 74-year-old with multiple comorbidities, limited life expectancy, maybe this isn't a priority. But this person's in good shape. So we see these nodules in the right lobe, nodules in the left lobe. And we can see this is back in an era where there wasn't TIRADS reporting. So it was a little more challenging back then. It's a lot easier now. But based on the size of one of these nodules, I say, let's biopsy it. And we get that atypia category, the one we probably hate the most. So I'm going to still want to watch this one for a while. I can't be entirely confident with that atypia. I could keep repeating the biopsy, but as I say, sometimes there's a limit to what the patients would go through. I watched them for a while, partly through the COVID era where maybe they weren't getting the imaging done as promptly. But after 8 years of follow-up, this thing is not changing, and it's time to stop and be reassured that the chance of malignancy is very low. And the next slide would be just me using my care pathway here, based on the TIRADS classification. If there's no growth after this 5 years, here it's a little prolonged. It's time to stop. Okay, Andrea.
All right. So if you can click, Omar, I want to show in the top the nodule in the right thyroid lobe. So that's on the top, September 2024, and that nodule has unchanged since 2005, actually. So has been a while that nodule has been stable. And on the right, I think, Omar, if you click again, I will exactly give a yellow rim so you guys can see that nodule that has been stable also for 10 years. If you click again, Omar, I think in the left will appear, actually this has been a spongiform nodule that has been there forever. And this nodule is completely benign. So actually we shouldn't be following this. So that's an important thing for us as well. Next slide. So as Russell was saying, some multiple thyroid nodules are less likely to be malignant. Always compare with the oldest ultrasound. So probably in this case, the ultrasound follow-up could be stopped earlier, right? Maybe. And remember, 5 years of stability is enough for these thyroid nodules. Next slide.
All right, so I think this is, there's one more actually. So this case here is a case from this year. I get one of these every year or two. So it's a young woman who had a firm neck lump, a lymph node in the lateral neck, actually, which she had seen, or I think her husband had seen, and got in to see her family doctor quite quickly, who immediately recognized this isn't good. It's certainly an unusual feeling thing, and was able to arrange an ultrasound quite quickly. And the ultrasound showed some suspicious features, which Andrea will show you in just a second. Got her into my thyroid clinic the next few weeks, and we did a needle aspiration of both a suspicious looking thyroid nodule and the lymph node, both of which were positive for papillary carcinoma. And she underwent a total thyroidectomy and neck dissection procedure for that. Quite a lot of positive lymph nodes, single sort of a moderately aggressive thyroid cancer. And so subsequently, she's gone on to see one of our endocrinology colleagues and had radioactive iodine treatment. The post-scan report, which was reassuring, showed no evidence of persistent disease at this time. So I like this case simply because, yes, they are out there, and so noting the features that are suspicious, you know, a lymph node that's unusual away from the thyroid, actually, and then a quick test that shows these features, and arranging for a specialist appointment. You know, you should always, when you send us referrals for, well, anything like this, you know, flag them as possibly urgent, and we'll definitely triage them and check the scans ourselves to make sure, yes, we need to see that person more quickly. Next slide.
Okay, so this is the ultrasound. That's the nodule on the left lobe. And I just want to point the 5 features that we assess on TI-RADS and the points that the nodule gets. So if you add all the points that are in red, this nodule has all the suspicious features, and that it actually has more than 7 points. So it's highly suspicious. It's a TI-RADS 5, and the FNA was absolutely necessary. Next slide. I just want to show the lymph nodes that are very abnormal. On the left is the ultrasound, and on the right, how they look on the CT neck. So the nodule is totally abnormal, and that's a suspicious lymph node, suspicious for metastatic disease. Next one. So in this case, a new neck mass in the absence of an infectious origin definitely should be investigated. It's totally reasonable to start with ultrasound in this case. And of course, a solitary thyroid 5 nodule definitely needs further investigation, like in this case.
Okay, so this one's, I don't think this is the one that I actually saw, but this is an elderly gentleman, 85-year-old fellow who's got heart failure, COPD, and multiple myeloma. There was an x-ray which showed sort of a narrowing on the right side of the trachea on AC joint x-rays. So an ultrasound was recommended, and this showed a less than 1 centimeter TI-RADS 4 nodule in the right lobe. So next slide.
Yeah, so here on the right, I'm just pointing in yellow at the little curvature that was mentioned on the X-ray. And on the right, Omar, if you can click to delineate the nodule, that's the sub-centimeter nodule in the right thyroid lobe. So definitely something that we don't need to worry about, and a very indolent nodule, incidental, actually don't need any follow-up. Next slide. So again, this is an old patient, so we need to be very mindful of our life expectancy, comorbidities, and other factors when we are evaluating these incidental findings. Always consider if there's any symptoms or not. Always weigh the harms versus benefit when we think about following up or asking for additional evaluation of this type of findings. And remember that most of the incidental nodules are benign. Next slide. Right.
Okay, I think we're ready to do the pretest again. We'll just see if things have changed. But you know what's really bad here is you've indicated the right answer. So I'm not sure we're going to bother polling because anybody who didn't vote right would have to be an idiot here. Okay, but anyways, what percentage of the population, if you do an ultrasound on them, will end up having a thyroid nodule? Some studies have suggested, like the one I quoted below there, 68% of us will end up having a thyroid nodule. So remember, be careful with this imaging, over imaging. All right, next slide. And remember that South Korea story, it was a real nightmare for them. The rise in screening for thyroid cancer that we saw, that's starting to taper off now with new guidelines, and particularly the TIRADS reporting, was associated with change in thyroid cancer mortality. There was no change. That was like signifying that we were picking up these very small cancers that were unlikely, papillary thyroid cancers, to cause problems in a lifetime. And then the next slide was what's the 5-year survival rate? Wow, we saw those statistics. They were pretty good. This was the overall was 98.4%. Even people with lymph node metastases still had excellent 5-year survival. So yeah, but we do see nasty cases, and I don't want to underplay that. But for the vast majority, this is a good prognosis cancer. And then the next slide would be what's the risk of malignancy with the TIRADS 3? So remember, Russell was saying, don't panic, just don't keep it in perspective. And that risk with TIRADS 3 was 5%. With 1 and 2, it was under 2%. With 4, it was somewhere between 5 to 20. And the 5, those are the ones that are really considered to be high risk, would be over 20%. But TIRADS 3 is still very, very low risk of malignancy. Overall, for most nodules, it's less than 5% will end up being malignant. Okay, and then I guess the last slide would be our take-home points.
Yes, perhaps before we get to those, there's some questions in the chat, so I'm going to see if we can address some of those questions for people. The first one, I'm going to ask this of Russell because it's a surgical question, so I'll read it out. So if the surgeon has in your clinic an ultrasound, do you think this will be better for the patient to rule out nodules in symptomatic patients and decrease load on radiologists? So do you want to do scanning in your clinic?
Well, we have not in Kingston anyway, we have a clinic that we run that's actually in the cancer center for thyroid nodules. So I do have access to an ultrasound there. The ENT clinic itself does not have an ultrasound. We've asked about it. And there's other things that we could use point of care ultrasound for other parts of my practice. So, having an ultrasound available somewhere is very helpful. There's ways of looking at the referral to say, oh, that's somebody I'm going to biopsy and that's somebody I'm probably not. So depending on that, I might schedule them at one or the other place.
Okay, thank you, Russell. The second question I think we've answered, or I think you mentioned that, Russell. Do you check adequacy of biopsy on site? And at KHSC, we don't. So we unfortunately don't have a cytopathology technologist on site. And places that do report a higher sensitivity and specificity for thyroid nodule FNA. So yes, that is the dream scenario. And if you do have that opportunity at your facility, in your institution, then go for it for sure, because it does improve the quality of the biopsies. Andrea, one for you. Do most private labs use TIRADS reporting for their ultrasounds?
I don't have numbers, but I know that there are places that they're trying to use TIRADS. We have been trying to spread the word and try to encourage everybody to use TIRADS so we can use the same language. But I think I don't have exact number to say which places are using that right now or which ones don't.
Yes, I think I agree with you. I'm just looking at the landscape in Ontario. I think vast majority of sites are using TIRADS. And as Robyn pointed out, if they are not, then what you should do is pick up the phone and call the radiologist and ask them to provide you with the TIRADS reporting system, because it is the standard of care for these patients. Just a comment here. I guess that patient counseling is a cornerstone in deciding to not operate on small thyroid cancer. Russell?
I'm going to say that, like in a lot of my work, but thyroid nodules especially, I think providing context and reassurance is a significant proportion of what I do with patients. it's strangely easier to just to make a decision, have a quick visit with somebody where there's a positive biopsy. These sort of uncertainties are where people get frustrated, and I get it. The likelihood that the science we currently have is going to improve our certainty is pretty small right now. And in a lot of the times when the science sort of quote unquote improves, to me it just makes things more confusing. So we have a reasonably good way of assessing nodules. We're starting to get a little bit more organized with it, and there's still a lot of conversation with patients. And you know, as we all know, some patients are far more worried about things than others, and sometimes for things that maybe they would benefit not worrying about. But I don't know how to help people stop worrying. So yeah, it's a lot of conversation sometimes.
It's never easy. So there's a question on the case 1, which was the patient who was followed for 5 years with no diagnosis. Did the patient or was the patient worried for follow-up for 5 years with no diagnosis? So basically, how did that interaction go with the patient who has a non-diagnostic biopsy ×2, I believe, and he was followed for 5 years?
So it just comes down to that patient counseling piece, and that you're keeping it in perspective with the patient about the excellent prognosis, about the low risk overall of malignancy. And I think people are really reassured when you say, I'm going to watch it with you. We're not going to forget about this. We're going to watch it. I don't have people ever complain to me about the ultrasounds. I say, I mean, are you tired of doing these ultrasounds every year? Most of them say, no, this is fine. This is not a big thing. So I don't find it a big issue with proper counseling and following the patients long term. And even in, remember Russell was telling you that some people are doing studies now and they're taking people with biopsy proven papillary thyroid cancer, and they're offering these people the option of active surveillance. Active surveillance means they're going to do ultrasounds every 6 months for the first 2 years, and then they're going to go out to every year. And people are picking that as a potential option. And in the studies that have been done, older people seem very comfortable with making that decision. Younger people sometimes change their minds, say, I want to have it taken out. But most people over 65 are more than happy to stay in the active surveillance group. So it's just, I guess the key is just ensuring them that you're going to keep watching it.
Thank you. There's a question here, why do a follow-up for 8 years in case 2?
And I'm embarrassed about that. 8 years of follow-up was definitely not needed. 5 is more than enough. And some of it's COVID, some of it's that TIRADS is fairly new, even in this center. So how we're approaching, but definitely if you follow that algorithm, the care pathway I showed you, 5 years would be more than enough. It's time to stop.
Thank you. Andrea, this is a question for you. What was the reason for the tracheal narrowing in case, I guess it was case 4? It's obviously not that little millimetric thyroid nodule that was incidentally discovered. So
Yeah, actually, I was expecting that the thyroid was probably enlarged, but it wasn't. So I guess this is probably just a technical issue. It could be just the projection, and the patient can be a little bit rotated, and it's not a real narrowing. Or if the patient has any other symptomatology, any underlying disease, maybe there's something else there that we cannot really evaluate with the thyroid ultrasound, right? Maybe there's something in the upper mediastinum.
yes, thank you. So there's a comment about posting the link to the pathway in the chat. I believe there's a slide coming up which has that link again, and you're willing to, if you are able to take a screenshot, you can do that. This will also be recorded, and from the recording, you will also be able to pick up the link, and I'll show you where to access it on the Department of, on KHSC website.
And I just put it in
But
the
if,
chat.
but if you can put it in the chat as well, I was just going to say that, Robyn, you have access to it right now. If you put it in the chat, that'd be great as well for people who can cut and paste it right now.
And just to remind you, this is local opinion. These things don't sort of exist. So it was just the endocrinologist here sitting around saying, this is what we do locally. But some of it's based on evidence, some of it's based on some TIRADS, but some of it's just based on local expert opinion. And oh, I should mention, if you have any questions, the best thing to do is sometimes to e-consult. If you're out of this area, just an e-consult, describe the nodule, tell me about the reporting, and an endocrinologist can often give you advice through the e-consult route.
And Dr. Houlden is being modest. A lot of that pathway is based on lots and lots of expertise and research. So it's a great pathway to have in the back of your hand when you see these patients. You don't know what to do. Okay, there's a question. Is there any experience with MRI neck and thyroid cancers? Andrea?
I think the best tool so far is ultrasound. I think there could be a lot of variability, and I don't think the detail of MRI and also of CT is as accurate as ultrasound for evaluation of thyroid nodules. So I don't know if you can say something more about it, but I don't think there's any real indication of MRI for thyroid nodules.
No, I agree with you. So MR and thyroid nodules is really a no-go, especially in the diagnosis and screening and follow-up of thyroid nodules. It's not the test of choice for multiple reasons, including some of the subtle features that you detect on ultrasound, such as those macrocalcifications, etc. You would completely blow by those on an MR. Where MRI might be useful is in some of these these aggressive thyroid malignancies, young patients where you're looking for spread to adjacent structures, metastatic disease to the lymph nodes, or bony invasion or cartilaginous invasion, and if that will make a difference to your surgeon in terms of management planning. So MRI next in those cases, or recurrent thyroid cancer after, or suspicion of recurrent thyroid cancer after thyroidectomy, for example, where you have some questionable disease on either on physical exam or an ultrasound that's been performed, and there's something in the thyroid surgical bed, then perhaps a high resolution MR through the lower neck would be useful, but definitely not in the front end of screening or evaluating these thyroid nodules. Next question is, as long as the patient knows his diagnosis, he can pick his treatment. My point is you can ask for adequacy check in the next biopsy after the one that was non-diagnostic. Not sure what question there is.
I think what he's saying is that if people know what they're up against, so it's showing papillary thyroid cancer, they can help in their own decision making about what treatments they want. But he's saying, I think he's saying it's frustrating when it's not diagnostic, and I think he's just bringing that up. And adequacy check, most of the time the pathologist is going to tell you, the cytopathologist, that I didn't get enough tissue to look at. So, but it's a frustrating diagnosis to get back. And I was showing you just some examples where sometimes you're stuck just watching them for a while.
Okay. So another question, this is for you, Robyn. Opinions on checking TSH with routine or annual labs?
I don't think that's recommended by any big groups right now. So most of the time TSH is just checked if people have symptoms of hyper or hypothyroidism, but routine screening of the entire population isn't recommended. It's usually based on symptoms still.
Thank you. And there's a radiology question for Andrea. Are there guidelines for recommending ultrasound for incidental nodules seen on CT? Should we be recommending for every nodule or for those only over 1 centimeter?
Actually, which is already quite old, I think it's already 10 years old, there is a guideline from the American College of Radiology on management of incidental nodules seen on CT. And what they recommend is that if there is a patient that, well, first of all, if you take into consideration the expectancy of life and the comorbidities, but in the general population, if you have a patient that is less than 35 years old, if the nodule measures more than 1 centimeter, you ask for evaluation with ultrasound. And in the patients that are older than 35-year-old, you ask for evaluation if the nodule measures more than 1.5 centimeter. Hopefully these guidelines are updated soon, but this is the one that we have from the American College of Radiology.
Yes, thank you. And that's been my experience as well. If you look really close on the average CT neck or chest or MRI neck, you'll pick up all these millimetric nodules all the time, you know, centimeter or just around, or 8 millimeter in this, and heterogeneous nodule. And so yeah, you leave them alone, essentially, you know, unless they've, as Andrea said, they fit that size criteria. And if they do fit that size criteria, the first thing you should do is look for a previous. And it could be, if it's a neck, it could be a previous chest CT or chest abdo-pelvis or MRI or previous ultrasound. You know, your previous is your friend, as your best friend in that case, rather than jumping to a dedicated thyroid ultrasound as your next step. Okay, I believe the Robyn, you had entered the care pathway, yeah, into the chat. So hopefully everyone can see that. You can cut and paste that, and I'll show you exactly where it resides on the slide coming up. So let's go to, and yes, we have time, so let's a few more minutes. So if you have any more questions, please feel free to ask or make comments. Let's go to our take-home points. Now that we are all experts in thyroid nodule management. So I think I'm going to read these out. So what the heck do I do with these thyroid nodules? There's some important takeaway points that our specialist speakers have shared with you. So number one, they're commonly found and incidentally found in a great majority of patients on physical exam or on imaging. Important to screen for those alarming features that Dr. Houlden mentioned and risk factors. Check the TSH if you do see that nodule that seems of high risk. If the TSH is subnormal, book a thyroid scan. Furthermore, using the TI-RADS grading, the TI-RADS is the most powerful tool we have, and from an imaging perspective, patients with the sole recommendation of clinical and ultrasound follow-up may continue to be managed in primary care without the need for a specialist referral. If there is no change in size and there's the magic number of 5 years, a nodule can be considered as benign. Here's where the thyroid nodule care pathway resides at KHSC, Kingston Health Sciences Center. You can log on to the KHSC website and search under refer a patient to KHSC. There's a whole bunch of care management pathways. So if you click on care management pathway quick reference list, you will come to the list, and the second on the list there is the endocrine thyroid care management pathway. So you can download that, print it out, take screenshots. It's right there for you. So as Pam said at the start, we're approaching the end, so we want your feedback. We hope that this was useful and interesting and informative. There's a post-program survey, and I think Pam entered into the chat just now. Please do fill that out. It's very useful for us to plan future webinars through our department and through Queen's University. Last but not least, this webinar is being recorded, and on the Queen's University Diagnostic Radiology website, there's a tab called Special Events, and you can access that on radiology.queensu.ca, and in that special events, and probably 2 weeks from now, if not sooner, this webinar will be there available for viewing. So everyone who is registered who did not get a chance to see it, or if you want to see portions or all of it again, it'll be there for your viewing pleasure. So with that, I'd like to thank CMODE, our sponsor, for bringing this webinar to us. I'd like to thank our excellent speakers, Dr. Russell Hollins, Dr. Robyn Houlden, Dr. Andrea Gallo, and of course, our DI coordinator, Pam Moore, who put all of this together. And of course, thank you to all of our registrants and participants. Thank you for everyone who asked questions, made comments. Hope this was very productive and informative. And please don't forget to fill out the post-webinar survey. Thank you very much, and everyone have a good evening. Thank you.